It is now my pleasure to turn the webcast over to Nick Beard. Sir, the floor is yours.
Thank you. Well, good morning, everyone, and welcome to our webinar conversation about the Two-Midnight Rule. My name is Nick Beard. I'm the Senior Vice President of Strategy here at MCG, and I'll be the moderator for today's discussion. We plan this morning on having our speakers give a fairly short presentation, after which we encourage you all to participate in the conversation. So, without any further delay, I'd like to introduce our speakers for this morning, John Shreve, who is the President of MCG, and Dr. Bill Rifkin, who is our Managing Editor. So, John, over to you.
Thank you, Nick, and good afternoon or good morning to everybody, and thanks very much for joining us. It's based upon the response we've had to this event, it's clearly an important topic to everybody. We have some thoughts we'd like to share to start the session about the rule, about documentation, about the government position, and about effective care in general. We'll be brief, as Nick said, because we'd like this to really be a conversation. And so please do take the opportunity to communicate with us, ask us questions, give us comments, and Nick will manage all of that information that's coming in and both share the comments and pass questions back to Bill and to me. But we're going to start with Bill to talk about what is the Two-Midnight Rule.
Next slide, please. Good morning. So a lot of the discussion around the Two-Midnight Rule should really begin with what the rule actually says and what it has been changed and what has not been changed very much. Certainly the two-midnight part of the Two-Midnight Rule is where CMS has introduced a new benchmark as part of its payment policy and became a final rule, and it takes into account and expects a physician to make an estimation of the length of stay of the patient in the hospital, specifically whether or not the patient will require more than one midnight, so 2 or more, or less than that. That's really the key decision, not so much will it be 4 days, 5 days, 6 days. It's really that estimation. Now, very importantly, that expectation is not just a seat of the pants type of thing. Like all the medical decisions in the record, this expectation has to be documented and defended and has to be based on their clinical judgment and the specific circumstances of the patient, and the reasonableness of this is going to be based upon what is in the medical record. So just like any other judgment that the physician has to make, it has to be explained and defended based upon the care they're providing to the patient. Next slide, please. To get really down to the nuts and bolts of this is that if we assume that the physician has explained their expectations, that if somebody is if they expect that the patient will spend more than one midnight, so 2 or more midnights, and the care is appropriate and it should be done where it's being done, that then becomes an appropriate bill under Part A of Medicare. If the expectation is for less than 2 midnights, then that is an appropriate bill under Part B. And this is trying to make it a little clearer for the users on all sides to understand when is something appropriate for Part A and when is it appropriate for Part B. Importantly, the time spent in observation care does count towards this midnight. So, for example, if somebody comes in on Monday morning and is in observation care until Tuesday, the decision being made on Tuesday is whether or not the patient needs one more midnight, because that would total 2. So the time in observation care can be very useful, but it also does count towards the midnight. Next slide, please. So I touched upon this, and I'd like to make this even more clear, if I can, that the documentation piece of the rule, I think, has been underappreciated. You know, the midnight piece of it has gotten everybody's attention, but and to some degree, what is said in the new rule about documentation is not new. It's always been the case that payment is contingent upon proper payment, proper documentation in the medical record by the physician, and that's often one of the sources of denial is that it's hard to tell from the documentation what was done and why it was done. But to take it directly from the rule itself, the Federal Register, is a physician's order and certification will be evaluated in the context of the evidence in the medical record. While the physician order and the physician certification are required, they are not considered by CMS to be conclusive evidence that an inpatient hospital admission or service was medically necessary. So just saying admit the patient doesn't mean, and they happen to stay 2 midnights, doesn't mean that a Part A bill is appropriate. It has to be, here's why I'm admitting the patient, and here's why they needed the time in the hospital they needed, therefore they were here 2 midnights, then a Part A bill is appropriate. It's been a bit misunderstood, the idea that you can sort of create a Part A appropriate patient by merely keeping them in the hospital, and that is not the case because there still has to be documented reasons for why the patient has been in the hospital for that time. Next slide, please.
So there are basically 2 questions that hospitals need to be thinking about when they're documenting admissions going forward. It's first, is this the right care to be performed for the patient? And second, is this Part A or Part B? So the first question is the question that we've always had, which is, what is the right care? Is this medically necessary? And the second question is purely a payment question. Is it a Part A or is it a Part B claim? But each of these 2 questions leads to 2 further questions, and you can see this splayed out on the screen. The first one has the question about should the patient be admitted, or maybe we should better say, should the patient be treated, and why, with sufficient detail added to the record about the patient and about what indications are for that treatment. The second piece, as Bill was describing, is not only whether that the physician expects to stay to span at least 2 midnights, but also why that's expected. And that then becomes the distinction on Part A versus Part B. Now the guidelines, the MCG guidelines, have the goal length of stay, and we also have indications in the guideline for extended stay. But not all of these indications for extended stays are things that the physician would know about on the first day of the stay, and so they're not all applicable. As the year progresses, we'll be providing some more support for the workflow that's associated with documenting that so that the evidence is available for the physician to make that judgment and document it going forward. I think it's useful to back up and say, why did CMS publish the 2 midnight rule in the first place? And what was happening, because of the auditing process, there were more and more longer observation stays. And longer observation stays caused a great burden to patients in 2 different ways. First, the patients had greater cost sharing under Part B than they do under Part A. And secondly, a skilled nursing facility stay required a Part A stay. And so if people were using Part B, they found suddenly they're in the skilled nursing facility and not eligible for payment for that. So clearly CMS intends with this change to shift more claims from Part B to Part A. And this again emphasizes that this is a payment rule that they're thinking about here. They're still going to be going back and looking at what things are necessary and not necessary when the various government agencies are auditing. But this clarification, as we all know, has caused more confusion than potentially clarity. These are some of the questions that people are asking now. How will RACs interpret and apply the Two-Midnight Rule? Are Medicare payments still at risk of denial? Have the documentation requirements changed? What role will evidence-based guidelines play under this new policy? Some of these answers are a little bit murky, but I think most are fairly clear. So the first one, how will RACs interpret and apply the Two-Midnight Rule, is one that I would expect over the long term, that will be, as a payment rule, they'll be looking at whether the payment, whether the hospitals were following the rules appropriately or not, and so that will become an issue that RACs will need to look at over the long term. They're being held back from this right now. And we expect RACs will continue to look at the medical necessity of treatment, whether it's Part A or Part B. Are Medicare payments still at risk of denial? Yes, for the same reason. Both the RACs and the MACs will continue to be looking at the medical necessity of individual treatments. Have the documentation requirements changed? Again, yes, they've essentially been added to. They haven't been subtracted from, unfortunately. So all of the documentation that was there before is still required to prove the medical necessity of the stay. And on top of that, we need the doctor's expectation about whether the stay will last 2 midnights or not. And finally, what role will evidence-based guidelines and criteria play under this new payment policy? Well, since the first set of documentation requirements have not changed, that part of the role of the guidelines have not changed. We expect that there is some very useful information in our guidelines that will help the doctors come to their judgment about 2 midnights, and that will also be useful to to hospitals as they're documenting the Part A versus Part B decision. But let me turn it back to Bill to talk a little bit more about the government's thoughts and response right now.
Thank you. So as you can imagine, with the Federal Register coming out with 1,500 pages of rules being promulgated through various contractors to different hospitals, it's not at all been made clear to hospitals and others that everybody is on the same page in terms of, and is fully understanding the implications of the rule and what it changes and what it doesn't change. So CMS has suspended enforcement of this rule until, this is the second delay, until September 2014 to give max time to probe in various hospitals for charts, find examples, and educate the users about what this chart would have been acceptable or not acceptable, and to sort of point out in real terms what how the rule would be applied. And that would be an interesting opportunity to observe that they're going to be looking at the same, they're looking for a 2 midnight sentence, but they're also looking at all the other stuff in terms of medical need to be where they are and what we did to the patient and why we think they need a hospital. Next slide, please. Okay, so here we sort of get down to more of the nitty-gritty. So, and this is a good way to look at the 2 midnight, it's almost, it's a goalpost, it's a yardstick to, in the past, a physician might have said, documented all their reasons, and then said, I think the patient needs to be hospitalized. Now the expectation is, after all the documentation and reason, is to say, I therefore expect the patient to require, at least 2 midnights of care, or to not require 2 midnights of care. So in the end, the bottom line is still appropriate hospital care. And two long-standing requirements that they've expected, since time immemorial is that hospitals have to provide the most appropriate care to a patient, higher level, lower level care, whatever is clinically appropriate, and they have to thoroughly document the rationale for the appropriateness of that care. Why does this asthma patient require an admission and observation care either failed or is not appropriate? Why am I going to try a period of observation care first and then I am going to reevaluate the patient after some observation and make my next determination? So it's laying out your thought process in, and one of the utilities of our content is that besides helping ground what is severity of illness, it also helps identify the key moving parts, if you will, to the decisions around patients. So this doesn't have to be a 14-page note, but there's sort of some key, based on our clinical indications, for example, some key, this is better, this is worse, this is the finding, this is what I looked at, this is the treatment I tried, and therefore, here's what I think. And those key sort of touch points and descriptors of the patient can make this job of documentation much more effective and efficient. Next slide, please. Another common question or misperception is the idea that with this rule, somehow it's simplifying everything so much that there's going to be no or less review by CMS and its contractors over care, and there'll be less audits, less denials. Some of these audits might take a different form. So, for example, they might be looking as much as, for undue delay of care. Once somebody is admitted to the hospital, did things happen in a timely fashion without delay? And that we have content that speaks to that as well in terms of what should be happening every day. But also, was this procedure necessary, and was this level of care necessary? To put it another way, two medical directors who work for CMS contractors have said, one said that providers who cease using any decision support tools are doing so at their peril. So meaning the idea that somehow this rule means you don't need guidance is flawed. And another one says, we are only in an education period for a brief time. If providers stop using tools like the guidelines, they will likely continue to see denials in the future. And, just the same rationale for why content was useful in the past is why it'll be useful in the future. Next slide, please.
So one of the questions that we've received while we've been going through this is, what is a RAC? So I wanted to stop and answer that one before we got to our bigger conversation. A RAC is a recovery audit contractor. These are the auditors who have been denying some of the payments that have led to more observation care, and that will also be continuing to look at whether payments for Medicare services are appropriate or not going forward. So on the next slide, the two best defenses against denials are first providing appropriate care, and secondly thoroughly documenting that care. So you want to make sure that the care is appropriate in the first place. It's very hard to document inappropriate care to prove that it's appropriate, and then following that up with the documentation that goes with it. The Medicare contractors, like the ones Bill was just quoting, will continue to gravitate toward places where the hospital has not documented the complex medical factors and objective medical information that are underlying the care decision. So it comes down to what it's always been. Provide only care that's necessary and document the medical judgment and the reason behind it. What's new now is providing the backup and the medical judgment for the physician's expectation of whether the patient will stay for 2 midnights or not, which includes the patient's circumstances and the reasons they're thinking about that. So when it comes down to it, we all want the same thing, which is the right care in the right place and the right time for patients. Hospitals want to deliver what's best for their patients. CMS wants to pay for what's best for the patient. And we're certainly very interested. It's our mission to provide the tools that support that optimal care. So as we head through this conversation, and before we dove into the conversation, I wanted to note that our client forum, which is coming up in May, will continue this conversation in a number of the sessions that we're having at that. We understand it is a very important question and issue to many of our customers, and that will be there at the client forum. So with that, Nick, let's start the conversation of what people are sending in.
Great. Well, thank you, John. Well, we've already had a number of questions come in from people who are dialed into the webinar. So I'd like to start by going with a question which I think I'm going to address to you, Bill. How should a physician go about determining whether the patient will stay more than 2 midnights? What factors should the physician take into consideration?
Well, that's actually a very good question, because when we went to medical school, we weren't necessarily trained in time prognostication, especially CMS's definition of various elements of time. So sort of, to some degree, it's the, if you, just like the old decision of, used to be admit a patient, discharge a patient. Then it became admit a patient or observation or discharge, and we sort of had to develop criteria in our mind for when observation care is useful. And one of the most useful elements of observation care, it turns out, which might be one of the reasons this rule is being created, is that if a patient is coming in and it's not clear that you're not able to clearly estimate, that, I don't know, this asthma patient might get better, the CHF might get better. I can't tell you right now if they're going to need 2 midnights. That might be a patient that is ideal for observation care, with the goal being to continue treatment and time, and then the next day make the determination with a little bit more precision then that, well, gee, are they ready to go home, or are they going to need more care? And if they need more care, they're likely going to have to stay another midnight. In terms of rules and criteria, the vast majority of the diagnoses and things that bring Medicare fee-for-service patients to the hospital, the vast majority of them, when a patient needs to be admitted, is there for more than 2 midnights. And the trouble came when these shorter stays that maybe were more appropriate for observation care were being billed as Part A. And that's where a lot of the denials and the discussion and the creation of this rule is. So it's clinical judgment. It's, trying to find out, well, how sick is the patient, and the therapy is likely to take how long to work. And if I really don't know, then maybe a period of observation care would help me narrow the question so that I'll be able to give a more precise answer tomorrow.
Thank you, Bill. So I have another question which I think is perhaps best addressed to you, which is what exactly does a physician need to include in the medical record to ensure payment for the admission?
That's another spot-on question. So I used to teach residents for quite a long time, and many of them would write beautiful notes. They were 12 pages, and they didn't really tell you very much about the patient, or at least what's going on right now, because they didn't know what was going on right now. They were good at telling you oodles about their past medical history. The content is basically a few key questions. What's wrong with the patient, or what may be wrong with the patient? And if you don't know, what are you doing to find out? Is this serious enough to require hospitalization, and why? Usually it's because of risk of not admitting them. They need monitoring. They need treatment that can only be given in a hospital. And then, importantly, what are you going to do to what are your interventions? So when you say the patient's sick, why do you say that? Don't just say pulmonary edema. Say pulmonary edema 3/4 of the way up for the reduction of oxygenation. So describe your patient as best you can, their clinical reality. What are you going to do to alter that reality, and when are you going to reassess? What are you looking for when you reassess the patient? So it doesn't have to be long. I mean, again, using our content and identifying sort of for any given diagnosis, there might be 3 or 4 key moving parts. Those are the areas to sort of get into the where, why, and what we're doing to the patient and what we expect the outcome to be.
Thank you, Bill. So, John, I think here's a question for you. Why do you think CMS remarks during the Open Door Forum that MCG criteria are not relevant?
Well, that's a good question as well. In that Open Door Forum, the question was, do you use the MCG or Milliman criteria or the interqual criteria as an indication for the 2 midnight rule? And I think CMS was getting a little frustrated with the question and answer, where they're specifically focusing on this being a payment rule. So where the MCG guidelines have always been focused on whether care is necessary or not, this is a payment question. And so we actually agree that when it comes to the payment questions, that is not what the guidelines were designed for. But having said that, I think that there is certainly information in our guidelines which will be very useful to the physicians as they make that determination of 2 midnights or not. For the base question of medical necessity, we are very much in the middle of that conversation. And of course, CMS contracts with us on an ongoing basis to help the various agencies make those determinations. And so it's in the context of the payment rule, though, you could argue that the current form is not relevant.
Thank you. So I'd like to just answer one question that a number of people have typed into the Q&A box, which is about the availability of the slides in the webinar. We are recording, and it will be available for people, and we anticipate that's going to take approximately a week before it's ready for distribution. So we will get this out to everyone. So I have another question, and I think, Bill, this is perhaps one that best goes to you. Someone has typed in a question that they have read that physician documentation trumps the MCG guidelines. Is that true?
Well, short answer, yes. Physician documentation, in fact, is the only thing that counts. That's one of the issues that comes up in these denials, is that a patient could look very sick by all their lab tests and nursing notes, but if the physician doesn't lay out what they're doing and why they're doing it, it's hard to defend an inpatient stay. So if I'm understanding the question correctly, if our guidelines are evidence-based and based on clinical reality, that means there's some gray. It also means there's times when somebody might not hit one of the bullets in the clinical indications and still has a very valid reason to be in the hospital. So our criteria include things like other reasons, other treatments. When you are using that box, your onus of documentation goes up that much more because you have to describe that much more clearly why you're doing what you're doing, where you're doing it. But if it's the content is designed to be used in concert with physician documentation. So if a physician's documentation adequately describes what's going on to the patient with or without use of our content, that would be fine. I think the issue comes up more often that freehand, if you will, physician documentation might not capture, just by, they're busy and there's lots of things going on, might not capture all the necessary moving parts that an auditor looking at the chart 6 months later who's never seen the patient, going just by the notes, would really get a sense of what's going on with the patient.
And I think it's useful, Bill, there, in the specific rule on the Two-Midnight Rule, there's this, let me read a portion of that out. I think it's useful to sort of hear CMS's view on that. It says, Medicare review contractors must abide by CMS policies, but are permitted to take into account evidence-based guidelines that may aid such decision. We also acknowledge that this type of information may appropriately be considered by the physician as part of the complex medical judgment that guides his or her decision to keep a beneficiary in the hospital and formulation of the expected length of stay. So they're really, seconding what you're saying there, Bill, that it's a physician decision that's very much, needs to be guided by the evidence, and it's very useful to have a good, solid source of that evidence that people are putting together.
Yeah.
So here's an interesting question that's come in from someone. I'll read it out. It seems as though the urgency of conducting an initial UR review has gone away with the Two-Midnight Rule. My first question is, do you support that view, Bill? And secondly, how can MCG guidelines help case managers dialogue with physicians who may have been skeptical about the guidelines to begin with?
Wow, so those are two good questions. So somebody gets double credit. So first, I would actually say that the design of the rule, the hope of the rule, and the hope of the contractors, and the hope of the clinicians and everybody is that more and more of these decisions are being discussed and considered in real time, as opposed to care is provided and then afterwards you try to justify it, because that's much harder to do. So it could very well be that through use of our, let's say in heart failure, we have a guideline that helps judge whether a patient requires an admission to the hospital. We also have a guideline that judges whether a patient is too sick to go home but still needs observation care. And that observation care guideline also has observation care discharge, so you know when you're done. And if you're not done, those form the admission criteria. So it sort of becomes a circle. So if it's unclear, if the physician doesn't know what to do, we have content to help you sort through observation care, meeting, not meeting discharge criteria from observation, will therefore help you support your admission decision. So I think that's as upfront is actually be very useful to have that sort of discussion up front. In terms of engagement with physicians, I would find that the clinical questions or the clinical points that the content is making. So somebody comes up with asthma. Asthma happens to be a guideline that has some fairly specific, because it's evidence-based, numbers on who needs admission versus who needs observation and who's ready to go home. So when somebody is making a decision around a patient like that, asking, well, it looks like peak flow is a very important determinant. Have we done a peak flow? What is the peak flow? Is that peak flow low enough? Do you think the patient would benefit from a trial and observation care? And it becomes, I know it can be delicate, but the idea that it's not rules, MCG doesn't let you admit the patient. It's more, MCG wants to help you ask and answer the right questions so that the right level of care is obtained. And hopefully, more and more doctors will see that as its use case as opposed to an arbitrary, somebody second-guessing their judgment. It's really designed to help them with their judgment the first time.
And Bill, I think sort of going back to the very early part of the question of the urgency of the upfront UR reviews diminishing, or I'm not sure if I quoted that right. I think that goes back to the two medical directors that you were quoting earlier in the discussion, where I think it's right that in some hospitals the urgency of those reviews has diminished. I also think it's a very dangerous place for hospitals to be. The CMS contractors are very much saying that if providers stop using guidelines or other decision support, they're likely going to be running into problems sort of as this sorts out going forward.
Right. It's not a free pass.
Yeah.
So a couple of questions that I think are related and both concern the measurement of the time around the question of observation care. The first question is, does the time spent in the ER count towards time in observation care? And then there's a follow-up question, Bill, about those cases where the MCG guideline has a goal length of stay of 1 day, and therefore may be considered as an outpatient under the 2 midnight rule. So maybe you could answer the first question first and spill into the second one.
Sure. So the first question, if I'm recalling it, is when does the clock start ticking? And actually, that is one of the areas where the rule was fairly clear. If anything, that's 1,500 pages can be clear, in that the clock starts ticking when care starts being provided. There's been some debate. Do you mean when the blood pressure is taken in the screening? Do you mean when the nurse first sees them? Do you mean when the doctor first sees them? And in general, it's been the loosest possible definition. So it's not sitting in the waiting room, but it is once you start care. Any care you provide, the clock is ticking. So if, whether it counts as observation care is an ordered status, so a physician has to write, I am admitting this patient to observation care. And that's when that starts. But it doesn't really matter, because in any event, they come in Monday at 6 p.m. and they get put in observation care Tuesday at 1 a.m., they've still crossed 1 midnight. And the decision to be made sometime on Tuesday is the patient better enough to go home, or if not, do they need to be admitted? And we have criteria around that. The rule, in its best angle, is that it's intended to stop sort of this ongoing, never-ending observation care. That pretty much, after 1 midnight, you have to either have before that second midnight, you're either better and going home, or you're not better, and therefore you're admitted, and that's an admission. And that was intended to make that piece clearer for folks. In terms of the...
Sorry, Bill. Go ahead.
In terms of the... it's the minority of guidelines, but in terms of the guidelines where our goal length of stay is 1 day, the way the criteria work does not change. It still is useful to determine who needs physically a hospital. The 2 midnight rule is not about where in the hospital you're sitting. It's whether or not you are an admitted inpatient. So this is saying that there is reason to admit the patient. Now, some of those patients that get admitted, if they attain the goal length of stay, which for some guidelines is a large number, and for some guidelines is a smaller number, and they do not stay a second midnight, that would be a Part B payment. If they stay a second midnight with good reason, because they weren't getting better, because other things happened, then that would be a Part A payment. So in those cases, the guideline is focused on, just like it sort of brings into focus that our guideline is about the appropriate care and place for the patient. And in some cases, so it doesn't come up, it won't come up a lot, I don't think, but in some cases, the payment policy of CMS will come into play in that somebody who's admitted who happens to go home before a second midnight the proper bill is a Part B bill.
So, Bill, there's yet one more follow-up question, if I may, just to make sure we cover up, because several people have asked this. 2 midnights can span anywhere from 24 to 72 hours, and some of our guidelines are 2-day goal length stay. Could you comment on that as well, please?
Yeah, so it's funny. Once this rule came out, everybody immediately recognized that once you put a line in the sand and call something the midnight, so yes, you can come in Monday 1 minute after midnight. So the rule doesn't change depending on when you come in the day. Now, I guess over time, this type of thing would balance out, that you'll have some patients come in at 11:30 p.m. and some will be coming in at 12:30 a.m. In terms of the content of the guideline, if something has a goal length of stay of 2 days and somebody comes in very early Monday, gets admitted right away, and is ready to go home before that second midnight, whatever percentage of patients that would be, it'd probably be a relatively small group of patients that were sick enough to be admitted but got better before that second midnight, that also would be a Part B payment. More often, people they would require that second midnight, and then it would be a Part A payment.
So, thank you, Bill. Here's a question from one of the participants in the webcast. Is there any indication that this may be coming to Medicaid in the future? Does anyone want to pick that one up?
I think historically what we've seen is that Medicare often leads in policies like this, but not always. And I'm no government speculator, so I won't say one or the other, but it wouldn't surprise me either.
Certainly not seen any concrete evidence of that so far.
No, and the SNF, the skilled nursing facility portion of the impact would not apply to Medicaid, and actually the difference in cost sharing between Part A and Part B would not apply to Medicaid, since Medicaid tends to have very low cost sharing independent of site of service. So the things that are driving Medicare to do it might not drive Medicaid to do it.
So there is a question about the application of the rule. CMS has suspended enforcement of the rule until September. After this point, are we to assume that any inpatient that has 2 midnight documentation will not be subject to audit? My impression is no. CMS has already directed the MACs to be looking at that question, and my sense is the suspension to RACs is a temporary statement as opposed to a permanent one, and that they will be looking again at medical necessity of shorter or longer stays as they go forward.
And they will also be auditing other things. There'll be, was the care delivered in a timely fashion? Another piece of this was they would be looking for what they call systematic delays in gaming of the system. So for longer stays, they're going to be making sure that care was provided that needed to be cared and as quickly as it could be cared for. And our content could be useful for that. For those of you familiar with it, we have content that sort of shows when a patient is moving through the system, what are some discharge criteria, and not meeting a discharge criteria can form a very important part of a clinician's note explaining why the patient requires to stay in the hospital. And that would be important to put in there, otherwise somebody looking at the chart might not realize why the patient couldn't go home.
Looking through quickly scanning there's a lot of questions coming in. It's clear that this is a topic that a lot of people are very interested in. Let me pull up the next. Bill, I think this one's for you. It's really about the way things actually happen directly in the ER. Do you believe that utilization review nurses definitely play a big part in determining the application of the 2 midnight rule? So many ER utilization review nurses seem to be the ones guiding the inpatient versus observation decision, and yet we've just talked all about the fact that this is reliant on physician documentation. Is that something you were able to comment on, Bill?
Yeah, it's a, I felt the pain of the previous person's question when they were asking, so, how do we get non-physicians to gently, politely, yet firmly get physicians to do the things they have to do? So yes, the use of utilization review in the ER at the time, to get it right the first time is much more important than trying to fix it up later. So it's of paramount importance that that person who is perhaps more familiar with the criteria and the guidelines and perhaps with some of the magic or key findings that will drive a decision either way is bringing, but yes, that has to be brought to the physician. The hope is that with lots of other things going on in healthcare, that with the proper incentives and training and experience, maybe the younger generation of physicians are going to come more and more receptive to this type of feedback. Could you please put in your note X, Y, Z? Can you please explain in your note why you think observation care is not appropriate? Hopefully, with more and more of the physicians becoming familiar with our content, they can then use it directly and be coming to the same questions and conclusions and suggestions that the utilization nurse is having to do.
So here's a question which may be more about the interpretation of the rules by the RACs than it is about the clinical context of the patient, but let's try this. Does a delay in care causing a patient's care to go past 2 midnights make that patient an inpatient?
So if you mean a delay in care, we don't do echoes on Sunday, so they had to wait till Monday, I would say no. That's actually one of the misperceptions that, nobody's going to be discharged at 1 day anymore. Everybody's going to be discharged after 2 midnights because therefore everybody's a Part A payment. So any delay has to be, and there's other reasons for patients to have delay. Things go wrong, they don't get better, and again, we have content to help you put that into proper words. Those sorts of delays, even if you expected them to go home in less than 2 midnights, but they don't, and they stay, and you explain why they stayed, then that's perfectly fine for a Part A bill too. But it's the, sort of delay for clinical reasons versus delays because the consultant didn't answer, didn't come in today. Those might be harder to explain.
The thing, if I were a RAC, and I don't want to be one, by the way, but if I were a RAC, I would immediately be focusing on hospitals whose 1-day stays suddenly decline sharply and looking for that very pattern, and that's who I would be going after.
I think they will. I mean, I think that's what they meant by systematic gaming.
That's right. That's right. Yeah, and CMS will direct them to do that as well.
Mm-hmm.
Yeah, there's a related question here, and I'm not surprised that there are a number of questions coming in about time and its definition in this context. A question here is, if a physician documents that the expectation of the patient is that they will need more than 2 midnights of care, but the patient then improves quickly and is ready to discharge after only 1 midnight, should it be billed as Part A or Part B? And Bill, the impression we've had so far is that it really all hinges on physician expectation rather than unforeseen circumstances. Maybe you can comment.
The rule made very clear in several places, and I made sure to note it because I know this is an area of extreme concern for physicians because we're not experts in predicting things yet. Early recovery is not, you don't get punished because your patient got better early. So if you documented for what looked like reasonable reasons that the patient would require more time, and they got AMA, you don't get punished for people leaving AMA or dying, or people recovering faster than expected and not staying that second midnight, doesn't mean you have to submit a Part B bill. You can still submit a Part A bill. It might be looked at a little bit more closely than other Part A bills to make sure that that original estimation was reasonable. But, somebody has really bad heart failure, they really look like it's going to take them, a while to get better. Lo and behold, their wife comes in to visit them. They get much better much more quickly, and they want to go home. There's absolutely no reason they can't go home. That wouldn't affect the billing.
Here's another question that's come in, which I think will be of interest to people. How does the Medicare inpatient-only surgery list intersect with the application of the 2-midnight rule?
So the Medicare-only inpatient list is the island of pure clarity in this whole business, in that if something is on the Medicare inpatient-only list, and these are procedures, a small number of procedures, they not only should be admitted, they have to be admitted in order to get paid. So, it's not the answer to this problem because it applies to a small group of patients. But yes, if the patient is having a procedure that's on that list, and our tool will identify, our systems are built so that if you type in that code, it'll tell you it's on that list, then, you should still write what you're doing and why you're doing it, but those have to be admitted. And so that's not, no matter how many midnights.
Thank you, Bill. Well, I think we're getting very close towards the end of our allotted time. And I think there are some other questions around, but some of them appear really to be more complex than the time we have available. So I'd like to let the participants in the webcast know that we do intend to circulate a document with the information about the recording of the webcast, where we will attempt to answer some of the questions we simply didn't have time to get to today. It's been really very encouraging to have such a large number of participants in the webcast and a very significant number of questions coming in, and it's always regrettable we don't get a chance to answer them all directly in the discussion today. So with that, I'd like to...
thanks to all who dialed in. Very much appreciate you taking your time to do that. And like you said, we understand that the large number of participants indicates the level of concern over this question among our customers. So thank you.
And thanks to our speakers, John and Bill, and thanks to everyone for participating. And that will be the end of the discussion for today.
Thanks to all participants for joining us today. We hope you found this webcast presentation informative. This concludes our webcast. You may now disconnect. Have a good day.